Bismillahirrahmanirrahim. Today we will discuss the hemodiafiltration in more details. We will start with the indication of hemodiafiltration. Not all patients are requiring hemodiafiltration, but there is no contraindication for hemodiafiltration. It depends on the availability of the dialysis machines and the cost-effective way. So let us start. What are most patients needing hemodiafiltration are patient with hemodynamic instability, patient with heart failure, patient with diabetic kidney disease and neuropathy, for example, patient on long vintage on hemodialysis, like patient more than 5 or 7 years on dialysis, patient with beta-2 microglobulin amyloidosis, patient with bad nutritional status or residual uric manifestation, even after optimizing the high flux dialysis.
او هايبوتنسي سيندروم برضه.
Intradialytic hemodialysis, hemodynamic instability like hypotension during dialysis, or patients cannot tolerate hemodialysis are indication for hemodialysis.
الهايبرفوسفاتيميك برضه احيانا.
No, hyperphosphatemia is not a way of hemodiafiltration. It needs a prolonged time, whatever you are using. So the time, because as we discussed that phosphate needing different models, so moving from the bone or tissue need time. So the time is a single factor important for phosphate removal. And even if you calculate the total phosphate removal between low flux, high flux, or hemodiafiltration, the difference is not so big. You are dealing about the difference between 600 and 700 milligram per session.
في بعض البيشنت عندها نوشن كده يا دكتور هشام، يقول لك ايه، انا هزرع بعد شهرين تجي لي بقى هيمودايفلتريشن عشان ايه يعني يشيل بقى.
There is no contraindication for
ماشي
hemodiafiltration.
بس مفيش انديكيشن.
There is no contraindication. You can do hemodiafiltration for naive patients starting dialysis, or patient has a complication that you need hemodiafiltration.
Impossible.
So for example, if the patient naive for hemodiafiltration and there is no clear indication, but it's in general the best way to remove your toxin.
Yes.
That's a very important point. Worldwide, it's about 20 to 25% of patients on dialysis worldwide are doing hemodiafiltration. The factors between economics between different countries are different. So you can find for Switzerland, 70-80%, and the Gulf area is 20 to 30%, and Egypt is less than 1%.
ايطاليا اعتقد وصلت 100% اعتقد.
Still, no one can single country 100%.
Almost يعني.
But it's increasing their acceptance for hemodiafiltration. So this is the basic selection. What are the requirements for hemodiafiltration? If you are implementing hemodiafiltration to the first time in a dialysis unit, you have to know that the following. Number one, you should have a better water treatment station. Number two, you have a system of piping system. There is no stagnation or bacterial contamination or endotoxin release during the process. And in Shams University, we are using the central dialysate delivery system, meaning that there is endotoxin retention filter, as well there is direct RO system, which meaning that there is no tanks. So it is comes from directly of the RO to the final hemodialysis machine.
From tape to machine.
And it is a mixer of dialysate composition solids dissolved mechanically in the tanks, and they deliver the dialysate directly. So there is no canister. And after that, you have to consider which best way of hemodiafiltration machine. For example, this machine, if you look to the back, you will find 2 endotoxin retention filter, and it's important to understand that the endotoxin retention filter are in series, not in parallel. It is enough for how many sessions? It's 100 sessions or 3 months.
Yes.
And if you are using continuously chlorine for disinfection, It's a maximum between 7 and 10 disinfection protocol by chlor. Remember that the machine tests the time of installing the endotoxin filter, the integrity of the fiber, there is no leak in the endotoxin retention filter, but never, they didn't test the endotoxin capacity of the filter. Here, what's called in hemodiafiltration, two barrier system, because you are using two endotoxin filter retention behind the machine. Some other machines are using the three barrier system, which means that two endotoxin filter behind and one disposable filter in the tubing of the substitution
اللايف.
in the line. And exactly this is the Baxter way. So after installing that, this is the machine of MSC 5008. It has two pumps. If you look here for any hemodiafiltration, it's at least two pumps. One for the blood pump and the a risk of clotting and extracorporeal damage. So usually we depend only on the automatic mode of hemodiafiltration. So let us go directly here. You can find the setup. Please be aware that if you open the door, the machine will stop the pumping. You have here a cartridge or a bag of bicarbonate, and this bicarbonate bag, usually you need higher than usual in hemodialysis because there is a lot of substitution. So we need at least around 900 grams of sodium bicarbonate powder and even 1.2 kilogram for patients on pre-dilutional hemodiafiltration. The difference is around 25 liters. The pre-dilution is around 50 liters and the post-dilution is 23 liters. So we discussed first to whom patients apply for hemodiafiltration.
وقتها.
Second point is the vascular access is crucial. Third point is the filtration fraction and automated mode. If you focus on a filter, as we discussed, the filter of hemodiafiltration should good ultrafiltration, should have an internal diameter better 200 and above for flow, should have a well-balanced sieving coefficient between most of uremic toxin like beta-2 microglobulin, myoglobin, and alloglobin. If you decide that you can remove efficiently the myoglobin toxin-like or molecular weight-like myoglobin, which is above 17,000 Dalton, this is the range of cytokines. So the myoglobin sieving coefficient is important to decide before doing hemodiafiltration to get the benefit of removal of
ما
cytokines.
تبقاش فلوس على الارض.
بالظبط. Let us go to the parameter, and if you focus here, you can find here one parameter which is very important is arterial pressure. Arterial pressure here is 115 on a blood flow 300.
Good.
This is a negative pressure, not a positive pressure like in venous. Because the negative pressure here is pre-pump, so it calculates the efficiency of the arteriovenous system. If you have below 200 millimeter mercury on a blood pump around 250 and 300, so we have a good functioning system. If you have here a negative pressure, for example, above 250 millimeter mercury on a blood flow around 250, you will have suction and you have interrupted flow, air, and subsequently complication. So this is the first parameter is the arterial negative pressure that measures the functionality of the vascular artery. I can consider here in this patient is good. If you go to the left corner, you can find the blood flow rate is around 300 milli per minute, and you can increase that if you need more of blood flow.
دي عامله كام لتر ايه؟
Here is a 2,500 removal of ultrafiltration. This is the different way. The patient need to be removed 2,500 milli per session as an ultrafiltration. But if you need to go to the parameters of hemodiafiltration, You have to check the online system to describe. Remember that here, they're recommending using Cordax. And this is the system built in the machine to use Cordax.
Yeah.
FX Cordax, because Cordax is better than FX Classic. Internal diameter is 200, exactly. And the Stevens coefficient of myoglobin is higher. So cytokines removal is important. Whatever the hemodialysis machine, you put the filter, high flux filter, it works. It doesn't mean that the system will be applied only for Cordax alone. If you go for that, after that ultrafiltration for the regular hemodialysis machine, but you can here check the online parameters. The online parameters we'll discuss here. The HDF mode is
post
dilution hemodialysis. So injecting post dilution. The volume here estimated substitution goal is around 22 liters. Professor Said say it's low. I said it's okay according to the patient.
What body weight?
This is young girl, around 50 kilogram in weight, or 55 probably, not more than.
وزنها كام ده؟ يعني ده رفض.
So it is more than enough because it's 23 liter per 1.73 body surface area.
فهي السلسله بتاعتها اقل.
Okay? So this is for young lady like this patient.
Acceptable.
It is very, very acceptable because the surface area is for
خلاص ده
surely
مركب سلام.
very small.
حلو على السلام.
Okay? If you go in here to the blood flow, you can increase the blood flow. You can find here automatic bolus. There is two mechanisms for protection. The automatic flow bolus, meaning that if the from huge ultrafiltration increasing in transmembrane pressure, the machine tries to push saline, stop ultrafiltration, and pushing saline inside the filter, so subsequently clearing the protein. Other one is the for substitution. And if you look that for the parameters of hemodiafiltration, we will start from the patient criteria and the patient selection. As we said before, that the patient selection is important because you have to select more patient need of hemodiafiltration, although there is no contraindication for hemodiafiltration. And if you look for that, the best one is the arteriovenous fistula in the hemodiafiltration vascular axis, because it's important to find a hemodiafiltration filtration fraction good, meaning that the vascular axis is important to ensure a good blood flow rate. Most of patients with catheter did not respond to hemodiafiltration to the optimum dose, except if you change the parameter or the time. The target hemodiafiltration dose is at least substitution 23 liters in post-dilution mode and 50 liters in pre-dilution mode. What is the difference between pre or post-dilution? If you focus here
بص
on the pump, it drains more of the dialysate, which should be sterile, meaning that endotoxin of the dialysate should be below 0.03 and bacterial count should be 1 per million. And this is freshly prepared dialysate going online substitution, while the offline means bags as in CRRT. So this is the offline preparation of substitution fluids, and if it is injected in the arterial line, it goes pre-dilutional, and if it is injected in the venous line, it goes post-dilution. The difference in the volume. For example, if you have patient with stroke or GIT hemorrhage, you don't need anticoagulation, so you can use the pre-dilutional mode because there is dilution of blood entering the filter and subsequently there is less coagulation. While using that, the blood flow is important to the filtration fraction. What's the meaning of filtration fraction? Is the fluid removal rate per the blood flow rate. Usual dose of hemodiafiltration is around 100 milli per minute substitution. And the blood flow, if it is only 300 milli per minute, so the filtration is 100 divided by 300, so the filtration fraction is 33%. Never to go above 25 to 27. Above that meaning
في
hemoconcentration.
ناس بتحبكها تقول لك 20 حد.
Yes, 20 in pre-dilution is easy, but here is difficult. If you are increasing the 25, the machine automated calculate the dose according to the safety of the extracorporeal surface. So you have an automated mode and the manual mode. If you change the automated mode into the manual mode of hemodiafiltration, you will clean and clearing the clog of the pores and this substitution. Another way is the back filtration on demand. Increase the transmembrane pressure, the machine stop ultrafiltration and start to push dialysate from the outside to inside, exactly calling ultrafiltration, back filtration on demand, on requirement, depending on the transmembrane pressure.
اجيب لحضرتك كرسي ولا مش؟
No, thank you. Other parameters does not differ from regular machine. Be aware that of the selection. Here is the venous pressure is 215, and probably this is for that flow is traditionally high. I will ask about the fistula needle size gauge. It is 16 or 17. It is 16. So 16 in this lady giving that flow, because if you are using 16 gauge, it is not recommended to go above 300 or 350
أيوة.
because hemolysis.
أيوة.
And if you have that 16 and this the venous pressure is high, be aware that on the venous structure
هو للاسف مش
fraction,
متوافر ال 15 يوم.
probably
مش
yes,
متوافر
I know.
مش متوافر للاسف.
Probably there may be some of stenosis. You know that arteriovenous stenosis, and they may induce recirculation and the clot. In all cases, this is the parameter of hemodiafiltration. Last point is what is the type of anticoagulation used. Usually you need more anticoagulation in post-dilutional. If you are using low molecular weight heparin, you have to inject that in the venous side. Because it's injected in the arterial side, 30% will be moved to these dialysate side
في الفينس
and less.
بلاش ارتري بعد كده.
And if you are using high molecular weight heparin, it is around 30,000 Dalton, high molecular weight or regular heparin.
وانت تحقيني ايه؟
So you can inject anywhere.
هنا هيبرين عادي ولا هيبرين؟
النهارده بس كان بقالها كام جلسه كده كان
البري بدون هيبارين دي او الهيبارين فري.
بنعمل بريك.
Exactly, you can do safely the pre-dilution. How to titrate the dose other than the estimated goal? For example, once you have the estimated goal of substitution of 23 liter post-dilution in other surface area, you can check monthly, for example, other biomarkers. Not urea, it does not differ too much between high flux dance and hemodiafiltration. You can check, for example, beta-2 microglobin reduction or other big molecule reduction ratio. So this is to stop here on the hemodiafiltration on the machine 2000, 5000 and
في اي اسئله؟
أسئلة بقى.
دعاء
ده